Welcome to our Immunology workshop video. Today, we will be focusing on the awareness of hemolytic disease of the newborn, which is also shortly referred as HDN. We are from Group 5 and our members consist of Ishwarya, Natalie, Yeting, Swetling and myself, Pravina. Hemolytic disease of the newborn, HDN, which is also known as erythroblastosis fetalis, is an alloimmune condition that develops in a peripartum fetus. This condition occurs when there is an incompatibility between the blood types of the mother and the baby, which causes the antibodies made by the mother to be directed against the baby's red blood cells. It is typically caused by a Rh incompatibility between the mother and the fetus. However, there are also other factors and incompatibilities that can cause this condition.
There are three causes of HDN, such as Rh incompatibility, ABO incompatibility, and other system antibody incompatibility. Rh incompatibility is when an Rh negative mother who has an Rh positive baby with an Rh positive father forms anti-D antibody, which will cause hemolysis or breakdown of the fetus red blood cell. This is because anti-D antibody is an IgG which has the ability to cross placenta and circulate in the fetus blood system. Usually the first pregnancy with Rh positive baby would not be affected by Rh-HDN because anti-D antibody is not a naturally occurring antibody, hence it requires sanitization. Consequently, it will only affect the future pregnancy with Rh positive baby. As for ABO incompatibility, an O blood type mother conceived with a different blood type baby such as A, B, or AB can cause ABO-HDN. ABO-HDN would affect the first pregnancy because ABO antibodies are naturally occurring antibodies, which means there is no need for sanitization. Lastly, other system antibody incompatibility involves antibody of Kale blood group system, such as anti-K antibody, KIT, MNS, and Duffy blood group systems.
Despite having a survival rate of 84 to 90%, in more than 90% of these cases does the child suffer with other complications. During pregnancy, amniotic fluid may appear yellowish, and when viewing ultrasounds, you may find the fetus having an enlarged liver or spleen. This enlargement is called hepatosplenomegaly. This disease is also commonly referred to as the erythroblastosis fetalis, following hemolytic anemia in the fetus, where immature red blood cells, called erythroblasts, are released into the circulation. UCSF Medical Center also highlighted the risks during labor towards the child, such as asphyxia, which is the deprivation of oxygen caused by the low number of red cells, as well as splenic rupture. Once the child is delivered, you may notice yellowing of the skin and whites of the eyes. This is known as jaundice and is caused by hyperbilirubinemia. Bilirubin is a product of heme metabolism, and since the baby's liver is still immature, it is unable to metabolize this compound. Now, what's dangerous about this is that if bilirubin enters and accumulates in the brain, the baby may suffer from kernicterus, which results in permanent neurological damage if the baby manages to survive. The baby will also have hepatosplenomegaly, as mentioned earlier. So what actually causes this condition? Well, the lysis of red blood cells leads to anemia. This results in something known as extramedullary hematopoiesis in attempts to produce more red blood cells to compensate for this low amount. Subsequently, this enlargement may lead to liver dysfunction or splenic rupture. Another chronic consequence of this disease is something known as hydrox fetalis. In this case, fetal tissues such as the stomach or lungs become swollen or edematous. If this occurs in the lungs, the baby will have difficulties in breathing. This condition is so severe that the child will actually die, either in utero or soon after birth.
HDN can be diagnosed when there is a blood group or blood type incompatibility between the mother and the fetus. So the diagnosis can be made during pregnancy, which is prenatal, or after pregnancy, which is postnatal. So prenatal tests include blood tests, ultrasound, MCA Doppler, amniocentesis, and PUBS. These tests will detect antibodies, bilirubin, fetal anemia, organ enlargement, and other related signs. For postnatal, a blood test can be done by using the cord blood to test for the baby's ABO blood group, rhesus factor, and other blood-related parameters. A direct antiglobulin test checks if the baby's red blood cells are coated with maternal anti-D antibodies, which is a sign of HDN.
Fortunately, HDN is a very preventable disease. Because of the advances in prenatal care, nearly all women with Rh-negative blood are identified in early pregnancy by blood testing. If a mother is Rh-negative and has not been sensitized, she is usually given a drug called Rh immunoglobulin, Rh-IG, also known as ROGAM. This is a specially developed blood product that can prevent a Rh-negative mother's antibodies from being able to react to the Rh-positive cells of the fetus. Many women are given ROGAM around the 28th week of pregnancy. After the baby is born, a woman should receive a second dose of the drug within 72 hours if her baby is Rh positive. If her baby is Rh negative, she does not need another dose. The drug actually is given to prevent your body from forming Rh antibodies, which aren't likely to harm your first baby, but could actually harm any future babies you have if they are Rh positive, because Rh antibodies could cause baby to be born with HDN. According to Desiderius Ramos, prevention is better than cure.
We have now reached the end of our video. Thank you for watching.